Hello, everyone. This is Dr. Manju George. Welcome to Doc Talks. We have today with us Dr. Andrew Epstein, and he's going to talk to us about patient-centered care in colorectal cancer. So before we get started, I'd like to ask Dr. Epstein how he got into this field of supportive care and to give us, to kind of take us through a day in clinic for him. Welcome, Dr. Epstein.
Thank you for having me. As was said, I am a gastrointestinal medical oncologist, and I work at Sloan Kettering Cancer Center, where I trained as a medical oncologist. And even as far back as high school and college, I was always interested in the humanities and psychology and following family members. I thought that medicine might be a good fit for me, and particularly oncology, because it spanned the biopsychosocial spectrum and was able to provide fulfillment and excellent care to patients and families across every avenue. And I had heard about and witnessed palliative or supportive care during my training as an internist, and was amazed at all the relationship building and treatments that could be given, and guidance that could be offered from supportive care specialists, which you're probably aware of and we can talk about today. So that's why I wanted to train not only as an oncologist, but as a palliative care physician as well, and why I am a clinician investigator who does research at the intersection of both disciplines. And so my average day when I'm in clinic, which is a couple days of the week, is that I am working solely as a gastrointestinal medical oncologist, with the majority of the patients I see having either pancreas or colorectal cancers. And I use the principles that I've learned and that I teach as a oncologist from my skill set as an oncologist and as a palliative care physician. And I do some time in the hospital as well as a palliative care consultant, but primarily I work clinically as a medical oncologist. So that's my practice.
Okay, thank you. We can continue with your talk.
Thank you. So like I said, it's a pleasure to be here. And this talk that I'm giving is titled Integrating Supportive Care into Cancer Care, because I believe that we clinicians who work in healthcare have a duty to answer a call that is both disease specific, because patients deserve the right treatments and diagnostic tests for their disease, but they also need to be seen as human beings with the disease, which is not a new idea, but is one that we sometimes lose sight of in medicine. So I think that this talk is important to understand how we can maybe get a better sight of that. I don't know if you want declaration of interest. I don't have any things that I see as conflicts. I do review topic reviews on GI cancer as well as palliative care for a reference called Up to Date, which you may be aware of, which has clinician as well as patient and family facing medical information. And I lecture on this very topic in some other avenues as well. And I sit on some professional bodies panels that relate to palliative care. This is the first slide that I'll show, which is an introduction and shows that supportive care, which we will use interchangeably with the words palliative care, is recommended by professional societies and by us at this hospital and others to be an integral part of any cancer care. So sometimes when people hear supportive care, or clinicians, particularly doctors, hear supportive care, they may believe that it is separate than the cancer care or the care that any patient is getting for any disease. And that's something that we're continuing to try to get away from, even though we've made a lot of progress over the past decades. This shows that cancer care travels alongside with supportive care on any journey, whether someone is cured or enters a survivorship phase of the illness, or whether someone dies of a cancer. And so, as I'll show in a moment, it's not the same as end-of-life or hospice care. But before I talk about that, I want to say that the NCCN guidelines, with which I think probably most, if not all of you, are familiar, make some pretty high bar recommendations about palliative care. And they say that all cancer patients, not just people who have progressive disease or who are dying, all of them should be screened for palliative care needs from the start and as appropriate moving forward. And they say that both patients and families should be informed that palliative care is part of the comprehensive cancer care, just like the last slide showed, and is not only for a certain time or population. And moreover, it's not just palliative care teams of specialists, but the mandate is for palliative care to be initiated by the primary oncology team itself, and then augmented, if needed, by experts of interdisciplinary teams from palliative care or others such as psychiatry or social work. There are many different types of teams that can give excellent palliative care. And they give a mandate for institutions themselves to develop their own processes by which the palliative care should be integrated into cancer care. And so I think that that is a high bar, but it's an appropriate bar to be set for clinicians because of the need for anyone, not just patients with progressive disease, to have palliative care. So what do we mean when we talk about palliative care? Again, interchangeable with the word supportive care, but this is a recent, I thought, nice patient-facing graphic and explanation of what palliative care actually is. And this was in JAMA Internal Medicine recently. And it says many things. It says that it's a specialty of medicine, which it is, just like cardiology or oncology or pulmonology. And it's for people with serious illness. And I don't think anyone would disagree that cancer, in whatever stage, whether it's stage 1 or stage 4, very likely to be cured or not, I don't think anyone would say that any cancer is not a serious illness. And so palliative care is a specialty aimed to help patients and families with serious illness, and is sometimes for patients with particular needs necessary as an additional layer of support by subspecialty experts called the palliative care team. But as I show on previous slides, a mandate for the primary oncology teams themselves to deliver this care. And they talk about on this slide the different things that it could entail. So it could be the management of symptoms like pain or shortness of breath, or worry or anxiety, depression. It can help with clarifying, well, what the goals of treatment are, which we'll come to in a moment as something that we often need to do in oncology. And it can help with making decisions, which are often very difficult, as we all know, in oncology or any other serious illness. And it's a team-based approach. So a standard palliative care team might have a chaplain, a pharmacist, a nurse, a social worker, and a doctor. And importantly, this slide shows on the left and in the graphic that this is not the same as hospice care. So a lot of people conflate hospice care with palliative care, and that's not true. Hospice care is a kind of palliative care, but there's much more palliative care that happens before hospice care, which, as you may know, is hospice care is the care that Medicare covers for patients who are expected to die within 6 months of a serious illness. So that is a special type of palliative care, and it's very important, and yet that's not what I'm talking about today. What I'm talking about today is broadly the palliative care that patients deserve to have, even when they're receiving tests and treatments for a serious illness like cancer. And so this is a cartoon that I often show, which is a cartoon because it's both completely absurd and it's got some kernel of truth as well. And there's this doctor who's sitting across the desk of a patient, and he says, "There's no easy way I can tell you this, so I'm sending you to someone who can." And this can pertain, for instance, in my practice to if I'm having a hard time understand why my patient still has a rash or why blood pressure is still high despite me giving blood pressure medicines, I may need the help of a dermatologist and a cardiologist respectively. But as an internist trained, I should be able to have at least some skill sets in dermatology, cardiology, and other aspects of internal medicine. The same goes for palliative care, where we need to help patients and families through serious illness. And so you can't have an oncologist or their team referring to a palliative care specialist at every single diagnosis of cancer. There needs to be some things that are done. And so that's absurd to say that we should refer everyone to a palliative care specialist. And yet it's both with a kernel of truth, because sometimes we all need a little bit of help from others, including palliative care or other psychosocial experts, to help with things that are particularly hard or intractable or remaining to be complicated despite our best efforts. So a really nice piece that was written about 10 years ago in the New England Journal of Medicine was this one by Amy Quill and Tim Abernethy, and they were delineating the tenets of, on the top, primary palliative care, which is what is really the purview, as I've been saying, of the medical oncology teams and even the surgical and radiation oncology teams also. And then there's the specialty palliative care shown in the bottom half of the slide, which is really the purview of the consultants, the specialty palliative care teams when things get complicated for things like refractory pain or other symptoms, helping with complex depression or other psychosocial aspects of care that are more complicated, perhaps assisting with conflict resolution between different parties that are involved. And yet on the top, again, primary basic palliative care is what I, as a medical oncologist, need to know how to do to manage pain and other symptoms like nausea that my patients might have, to help them with their mental concerns and diagnoses like depression and anxiety, and to talk about where we are, what this cancer entails, and particularly, as I circled there, the goals of treatment. That's something that we often talk about in medicine, particularly oncology, as, quote, the goals of care. And as I'm going to show here, that's something which we often think is only medical, but is entailing much more than medical things. The writer and the physician that you may know, Atul Gawande, wrote a book called Being Mortal more than 10 years ago, but almost 10 years ago now, who said a couple things in this passage that I thought were worthy of comment here. He said, first, in medicine and society, we have failed to recognize that people have priorities that they need us to serve besides just living longer. Now, that may be true. There may be some patients for whom that is their one and only, or at least their highest priority, and we should respect that. But not for everyone. And regardless, Dr. Gawande says, second, the best way to learn about those priorities is to ask about them. And I don't think we do that enough in medicine, particularly in oncology, which is one of the reasons why I was spurred to try to enhance my practice and my research with palliative care. We've written about the need to know and feel known, that patients have this double need. They need often and want to know about their illness, but they also have a need and an intrinsic a need to feel known as human beings. So we're going to talk about how the goals of care really need to be built off of both of those things, not just the disease, but who the patient is as well, which again is the title of this talk. And this has been written about in other ways as well. This group talked about how collaborative decisions in medical care and balanced medical recommendations themselves are built upon the pillars of not just the medical story. What is the colon cancer? Is there a BRAF mutation? Is there a right-sided tumor or a left-sided tumor? Is there metastatic disease or not? These are all very important things, but these are the medical aspects, and you need to have the patient's story as well. Who is the person? What is important to them? What are their concerns? What are critical abilities so important with which they couldn't live? And many other things about the patient. So we're going to talk about how we get that. And these things need to be elicited after there's a relationship of trust that's built between patients, their families, and clinicians. And so I want to talk a little bit about the stab that we've taken at all this at Sloan Kettering. And this is not the right way to do things. There's no right way to do things, but this is the way that we've tried to answer the call from the NCCN as our own institution, to try to answer the call to make sure that patients and families are given palliative care from the very start of cancer care, no matter what. And again, it gets at primary supportive care as shown in the bubble on the left. So this is something which we believe all primary medical, surgical, and radiation teams need to be able to do. And we've called this the Transitions Initiative, recognizing that there's often many transitions in the cancer care journey, such as diagnosis, progression, cure, debility, death, and other transitions. And so we've bucketed this into two main buckets, if you will. The one on the left we're going to focus on today. The one on the right was not something that we have time to discuss today, but focusing on communication about transitions, we've tried to have a framework by which we can have discussions, documentation, and a display for other clinicians about what has been discussed in terms of the patient and the overall goals of care. So I'll touch a little bit on these. When the pandemic happened, there was a even more than usual urgent need to assess what patients' goals of care were, because on top of the cancer, we had serious illness, and sometimes, as you know, with the virus, death, or at least critical illness, such that we needed to assess goals of care urgently. And so we had some clinician-facing tools, both on iPads and cell phones, that clinicians could reference in terms of some really high yield questions that you see here that we will talk a little bit more later, so that they could perhaps more expeditiously discuss goals of care, even though we wish we didn't have to in the pandemic setting in a more rushed way like that. And otherwise, we also facilitated through a vendor called VitalTalk, which is kind of the industry leader in communication skills training, opportunities for our oncologists, who are already very good, I believe, at communicating about serious illness, additional training to take part in one of two courses. The first one being Mastering Tough Conversations, and then another one being a Train the Trainer model, where people could take those skill sets and try to spread them to their services and beyond, using skill sets they learned about how to teach these skills in communicating about serious illness. And so there were a couple dozen oncologists who were faculty, half of whom were oncologists, half of whom were supportive care clinicians who were interested in elevating their skill sets in communication, 12 of whom went on to then become trainers of other clinicians here at Sloan Kettering. And this is an initiative which is continuing, and this is a screenshot of the Zoom that the Vital Talk founder had with a handful of our faculty, and is broken up in small groups in its role play setting. And this was very positively rated and thought to be helpful by the faculty. And in addition to training about discussions, we thought it would be necessary for the medical record to be helpful for the clinician to document what had been discussed in goals of care discussions. And so we've worked over the years, and we're actually now working again because our medical record is transitioning to Epic, which is a more commonly used medical record in medicine. But with our current and older medical record, we developed this goals of care template for clinicians to be able to document what conversations they had with patients and families about the goals of treatment. So the goals of care template, as you see here, gives the clinician options to check a box to indicate what was discussed, such as the expected course of the illness, the intent of the treatment itself, what the patient's goals were, and even gave an opportunity for a discussion about end-of-life care should the patient want to talk about that. It was not mandated or suggested that there should be a discussion about end-of-life care, but that is obviously pertinent if someone is having a progressive cancer and if they will die of a cancer. And so the end-of-life care boxes enable a discussion of what we call code status, as well as hospice care specifics. And so in addition to these check boxes, there could be free text for clinicians to indicate what actually was discussed during the conversation and to summarize. And what we found is this plot showing both on the inpatient and the outpatient side, after the institution had supported during the pandemic a need for goals of care conversations to happen, and when we were supporting patients with clinicians with training and places in the medical record to document it, there was, as you see here, an increase in the numbers of goals of care notes that were entered into the medical record, both on the inpatient and the outpatient side. So this shows that clinicians in busy practice settings can be motivated and moved, given the right tools, to actually do primary palliative care. As I mentioned, this to be one part of, we've done some research, including in this paper shown here, that the documentation of these goals of care using the templates that I just showed you by medical oncologists is associated with end-of-life outcomes. Now, I'm not saying that end-of-life is the only thing that matters for us to talk about goals of care, not at all. However, it's pertinence. And so this study showed that patients who were admitted to our hospital in the last 30 days of their life, among those people, if there was a prior documented end-of-life discussion using this template, these were people who spent less time at Memorial Hospital and were more likely to be discharged to hospice care. Again, I am not saying that less time in the hospital is better, and I'm not saying that hospice earlier or at all is better. We do know, however, that for many people, these things are preferred and are appropriate. So all I'm saying here is that the actual use of a template and a discussion is associated with these things, and therefore might be relevant to consider when thinking about how places should have their own systems by which these things happen, and about how patients and families might want to talk about what is important to them, whether that be a focus on comfort or ongoing hospitalizations and tests and treatments of a cancer. Whatever the patient is most prioritizing, that is what should be considered by clinicians and their teams. We also worked hard to have a place in the medical record that was not just about blood tests and scans and the doctors and nurses note, but actually about the patient, him or herself. And so we were able to have this somewhat coveted real estate in the medical record called the Patient Values tab, which has multicolors and houses information about who the person is as a human being, in addition to the molecular and other specifics of their cancer itself. And it entails everything from communication preferences on the top left, how the person likes to be called, how they like to receive information with a lot of detail or less detail, some things about their practices and beliefs. It gets to things in the bottom left about illness and treatment understanding, which are prognosis questions that I'll show you we've experimented with asking patients no matter what. Some of the nuts and bolts of what we call advanced care planning, like who are the proxies, are there any advanced directives in the system, And in the middle, the goals of care discussions themselves are on the top in the purple. Those are the things that I've already showed you. And in the bottom center, I'm going to show you a little bit more. It's an initiative and ongoing research that we have surrounding what values patients have in terms of what they're hoping for, what their concerns are, and what their critical abilities are. So we've worked to have a place for patients' personhood, not just their medical specifics in the medical record. And we think personhood is important because it shouldn't need to be argued, but I'm going to show you how this has been playing out in the medical literature. This is a New England Journal of Medicine essay by a physician who herself was a patient around the time when she wrote this piece in the medical in the New England around 5 years ago, where she talked about the reality of cancer curve in medical research. Sometimes we do something called an ROC curve, which is a curve on the axes like you see there. She took her own take at a ROC curve and called it the reality of cancer. And she posited that there isn't just things that threaten our lives as cancer patients, like the cancer or the treatment with its risks, but there's also things on the x-axis, on the horizontal axis, that threaten our days and the quality of that, like feeling bad through the complications of cancer treatment, the complications and the worry about the complications of cancer treatment, the anxiety about what's going to happen, the strain it places on relationship and our work lives, and even with ourselves. And so this writer said this ROC curve is the yin to the omics yang. And when we talk about omics, we're often talking about genomics, which are the specifics on a molecular level of the cancer. And she recognizes that as very important. But like one of the other slides showed, there's not just the medical aspects, there's the patient as well. So it's this yin and yang. And she says this ROC is the yin to the omics yang of precision and personalized medicine. She says we need both, which is what this whole talk is arguing. You have to have both. And by specifically mapping out the things that threaten our patients' days and lives, we optimize our sensitivity to the lived reality of their experience, basically allowing patients to live better days in ways that are important to them. And she says the welcome news is that the area of the curve can be manipulated. What threatens the lives may be immutable, but there's ample opportunities unique to each patient to move the sliders and reclaim the quality of their days. And I think curiosity has a lot to do with this. Curiosity on patient and family parts, but really a lot on the clinician's part. So I teach some of the clinicians this piece that I read in the New England, sorry, not the New England, in the New York Times Magazine. Many of you may be familiar with Neil deGrasse Tyson, and has nothing to do with medicine, but as you know, he's a physicist, and he had this really interesting answer to a question that was posited to him in an interview. And the question was, we don't always recognize misinformation for what it is. And obviously misinformation is large on the political spectrum these days, but there's also things, as you know, about science and even medicine. So the interviewer says, what are the questions should people be asking themselves when they encounter material that's skeptical about mainstream science? And Tyson says, what's behind all this? The missing link is curiosity. And so this is what I'm suggesting patients and families come with. If their doctor is saying, you must do this, well, you might have curiosity and ask some questions. Why? Or if they see in a community chat group or somewhere else, my doctor said I should take this, I do this, and therefore everyone should do this. You should have some curiosity and say, well, what is it? And so the interviewee says that without curiosity, you're no longer probing for what is true. If someone says, I saw Bigfoot the other day, there are people who say, yeah, that's great. And there are people who say, no, you're full of crap. Both of these responses require no brain work. What is the brain work I would like to see more of? It's, quote, tell me more, which I teach as one of the most impactful communication questions that you can have with patients and families. Tell me more. When did you see this? Where did you see it? So did you find other evidence? You start probing. It's the absence of curiosity that concerns me. And so this is not pejorative. This is simply saying that I think that we need more dialogue in our society, including in the exam and hospital rooms between patients, families, and their clinicians. And again, this is not new. Communication is very important. There was an internist who said that patient communication is the most common procedure any clinician will ever perform. So even if you're a pathologist or a radiologist or a surgeon, these are very important medical subspecialties. These people need good communication. A pediatric oncologist who's also a writer once said that talking is our procedure as oncologists. So we need to be good at this. And it's a little skeptical, but there was a layman who once said the problem with communication is the illusion that it has occurred. And that's because sometimes there are oncologists and teams who don't address these non-biomedical aspects, despite the fact that patients and families deserve for the biomedical aspects to be addressed and for the psychosocial aspects and their priorities, goals, and preferences to be elicited as well. And so patients and families should ask for time about this if that's important to them to talk about, if it's not already being addressed, and we'll come back to that. So one way that we've tried to make special space for this to be discussed is as part of what we call the 1, 2, 3 project, which involves, as I'll show you at the first, second, and third follow-up visits, to talk about 3 things that we think are important: symptoms, understanding, and what we call values. And in the values aspect, which is of most interest to me, we've published on discussions that were originally led by oncology practice nurses who are really trusted and know the patients very well about what their values, what the values of patients are. And this would be around 10 minutes, and it would be revisited quarterly. And then the nurse would, after verifying with the patient what the discussion had entailed, they would then document in the medical record what the discussion had been about. And it would populate that values tab, showed that multicolored area of the medical record. So again, 3 things: symptoms, understanding of illness and their treatment, as well as how much information they want to have when they're making decisions and having discussions about their illness. And then finally, their values, which happens about quarterly in our research. And so these are the questions that we've used with a lot of patients, hundreds to date, that are informed by our research as well as research of others that you can read about if you want, in the references shown on the bottom. But we give them an introduction every single time we do this, so it's not out of the blue and people don't get concerned that we're talking with them about their values for any specific reason. We tell them, as shown in the black at top, we do this with everyone, regardless of what's going on with you, because we think it's important to know you better as a person. And then these blue questions ask things like you see there. First one's called the patient dignity question. What do I need to know about you to take care of you as a person? And that can be really appreciated and impactful. And these are very highly rated questions in terms of patients and families finding these being helpful, comfortable, and recommended to others. What gives you strength? What concerns do you have? What are you hoping for? What else are you hoping for besides that? What abilities are so critical in your life you can't imagine living without them? And then we give patients an opportunity, if they want, but we don't force them to answer, to discuss what they would want if they were in a crisis situation, like if their heart were to stop or they couldn't breathe. And we ask them finally if they've discussed these things with loved ones, because we think that that's important for those discussions to happen, so loved ones can understand what's happening, what is important as well. There was a doctor recently this year, this is an oncologist in Brooklyn, not at my institution, but he wrote this lovely essay in the JCO, which is the Journal of Clinical Oncology, and he talks about the importance of values elicitation. So I found this to support our work, which I thought was very nice. He said, we need a conceptual nudge. Otherwise, if we're just left stranded at the lowest common denominator of value, which is money, institutions may measure the end in the flow of dollars, but the beginning lies in a generous spirit, an awareness, and in a way of thinking and acting that places protection of the vulnerable human person and enhancement of the quality of human relationship front and center. This spirit ought to shape both personal relationships and the larger systems that influence relationships. That's what we're trying to do at Memorial and beyond, is to try to get this part of culture so that it's not all about more tests, next patient, keep it going, and a breakdown in communication and an absence of understanding who people are and what's important to them. Because these questions sometimes, but usually not, sometimes are of sensitive nature and make patients upset, even though that doesn't usually happen. We were training the nurses in what we call the acknowledge, normalize, and partner framework, which is a variation on other empathy communication skills frameworks that's been in the literature. But this was a really nicely pared down framework for nurses to learn quick tips, if you will, about how to respond to emotion if it arose. Phrases like, I'm glad you shared this with me, or normalizing it to the notion that many patients feel this way in difficult situations like this. And finally, partnering with patients, which is very supportive, that we're always going to be with you in this no matter what. And so we've been pleased with the results we've had with our programs thus far to have discussions, and we realized it was so acceptable and it was actually moving the bar in terms of patient-rated quality of communication. We are now embarking upon research that would use the patient portal, which I'm sure you're all aware about, is something that patients and families increasingly have access to and increasingly use, to use the portal to actually send patients these questions, which is inherently less personal than having a discussion with a nurse one-on-one, but a better way to scale it from hundreds of people to thousands. And that's what we've been doing and what we're continuing to research about these things getting sent to patients and families, and then it being sent to the clinicians, who then are encouraged to have discussions about the answers and then to document it in the medical record. And so this is our ongoing research. And in the last remaining slides, I think I have 3 or 4 left, I want to touch on some other things that are common at the interface of disease and being human as a patient. One of them is Scanxiety, and people here may have experienced this. This is increasingly written about, including in this nice review about Scanxiety. And it shows, as we all know, that scans are common, but they do have risk. They can be a psychological reminder of the diagnosis that happens, an indicator about the uncertainty about what's going to happen in the future, a focal point for clinicians to need to know what's going to happen with the disease and the course of the illness. It could be scary if patients' cancers are progressing, and what that implies for treatment, if treatments need to be switched. Scan procedures themselves can be unfamiliar. Claustrophobia factors into MRIs a lot of the time. They can be uncomfortable. There can be some concerns with radiation exposure or other issues that happen. And so scans are not perfect, far from it. And there's a thing called Scanxiety. And so this is, I think, one of the most common things about, most common examples about how things that we oncologists do as tests can have downsides. And so other possible things are the routine blood tests. It's not necessary, in my opinion, for me to know what the percent eosinophils are on a blood count of someone with colon cancer. The very minority of patients with human disease need to know that level of detail, and yet that's common in a complete blood count. Is some of the things like that. And so routine blood tests themselves can be concerning to patients, and sometimes doctors, I think, can act too much on a tiny off blood test results. The tumor markers themselves, such as CEA with colon cancer, is something that does, in my opinion, have value, and it also has downsides. For instance, the decimal points. We had, I think 20 or 30 years ago, petitioned the lab to please take out the decimal points, because going from 5.1 to 5.2 might upset patients, and yet it has a negligible import on the diagnosis given the noise in the system. And yet we were unsuccessful at having the lab to take those out. And so we often have many conversations about what does it mean to go from 5.1 to 5.2, or what does it mean to go from 3 to 5? And it may or may not mean something for the disease, and yet it often can be concerning for patients, families, and clinicians. And then there's the liquid biopsies, which is beyond the scope of this talk, but something I'm aware of is increasingly prevalent in colorectal cancer and others. And so I believe that there are downsides to liquid biopsies. I believe that there is a lot of research that has to continue to come out to prove what we hope to be true, which is that they're helpful in navigating the illness course between patients, families, and clinicians. And so I think patients and the clinicians need to work better and work together to navigate the benefits and the burdens of scans and these tests, in my opinion. How do we use tools to facilitate communication during consultations in cancer care in general? There was a nice review of this a few years ago, and there's many things that have been looked at, whether it's patient-reported outcomes. You may, as a patient, have been part of clinical trials or even common clinical practice now, where you're asked about common symptoms before your visit with the doctor, anywhere from shortness of breath to tiredness to constipation. And the data actually show that this improves quality of life, decreases emergency rooms, and increases overall survival. And so this is something which can be very useful if done correctly. There's other things like question prompt lists. These have been researched in terms of maybe you give patients and families a list of questions that they can use and prompt them and say, ask this of the doctor, so that you make sure your questions are answered about what is the treatment schedule and what is the side effects and what are the options if we don't do this treatment, and how often do you monitor cancer progress. And these are prompt lists that have been researched. There's audio recordings, which are increasingly used, and with technology is often helpful for patients and families to be able to have a recording so that they can actually listen to the doctor instead of writing things down, or if they forget something, to go back to it later. Records being in the hands of patients themselves is increasingly prevalent, if not law right now, and I think very helpful in general. And there's other things called informational aids like videos or prediction tools. The takeaway, the research from this kind of meta-analysis was that the evidence base is mixed. Some tools are likely more helpful for some patients than others, and some settings may have them available and some may not. So this is somewhat of a mixed bag, but can be very helpful sometimes. And what is the patient and family role in their cancer care? You all probably know this, but I want to have this slide, which is my last slide, to encourage you, as I've been saying, to think about what's important to you as a patient. Really think about that. And granted, you don't know the future, and you might not know the ins and outs of a disease, especially if it's a new diagnosis of cancer. But you can think about what's important to you as a patient, and we find that values are enduring, even though the quote-unquote goals of care might change depending on what happens in the medical situation. And how much detail do you want to know? Most people want a lot of detail, but sometimes we doctors, because we are, we have been said to be talkaholics, where we like to talk. Sometimes we give information to patients who didn't want it at all, or didn't want it in that level of detail. And so we ideally should be asking you how much detail you want, but usually we don't. And so you need to know how much detail you want, and you need to interrupt a doctor if they're giving you too much detail, and you need to politely ask for more if you're given too little. That's both during an appointment as well as before and after. You have access, as we've said, to a lot of information, both the patient portal results, clinician notes now as part of law, and you should look at those things if you want, and you shouldn't if you think it's going to be not helpful for you. You have other resources outside of the clinician-patient relationship, from support groups and other informational resources. Try to ask yourself, what's the quality of the informational resources? Use that curiosity that Tyson talked about. If a patient in a chat group is saying, my doctor does this, I recommend it for everyone, ask why. Ask, is it important and worth it and applicable to you or not? And ask your doctor that. What's the quality, as I said? Who should be present during appointments? Some people want to be alone. Most people want someone else there with them. If they can't be there in person, maybe have them over by phone, by speakerphone, and ask the clinic staff to set that up. And that can be really appreciated by the clinician, so that everyone can be on the same page. Consider writing down your questions so that you have them at the ready, either during or after a medical consultation. And then finally, family and friends are so important. They are in a hard spot because they don't know what the patient's body is telling them. And as I often tell patients, listen to your body. And I tell the family, listen to their body, because they know it best, and ask them what they're feeling. Are they hungry? Are they not? Do they want to go for a walk? Do they not? What's important to them in addition to what's important to the concerned loved one? And so this is how I'll end the talk, and I appreciate your time again, and I'm happy to take questions if there are any.
Thank you very much for the talk. So I think maybe I'll start by asking about, how to communicate prognosis information to patients. It comes up in a lot of discussion in Colontown because there are a lot of people who are stage 4 who don't want to know their prognosis, and they're told that their disease is incurable, and that and when they hear that word incurable, they are thinking that, or terminal, they think that they're going to die immediately, whereas many of these patients might have not that extensive disease, but the term is just used to say they're not stage 3 or not non-metastatic. So what would be something that they can, how to control this conversation, what to say to the doctor? So saying, I want to know my outcomes, but I don't want you to tell me in those terms.
They should say that exact words or something like it from the very beginning, if they are feeling like they're going into a consultation where a serious prognosis is going to be discussed. And the clinician will probably appreciate it. The clinician does usually, if not always, has an ethical obligation to discuss a situation, if not with the patient, then with a loved one. Because if there's going to be medical care delivered, there has to be some semblance of knowledge from someone, whether it's the patient or their family, about why is this being done and what is actually expected from this. That is just sound medical care. That being said, there need not and should not be a information dump, as we call it, or a hitting over the head with information that patients are A, concerned about hearing, and B, might not need to hear. Now, So that's what patients and families should say. Just so you know, please, we understand we're in a healthcare setting and we need to be told things. We understand that. We are concerned about X. So if you could please not say A, B, and C, that would be helpful. Now, this can be challenging for clinicians, and yet that doesn't, that's the way it is. Not every job is easy. And when you have the honor to be a physician, and you're going to be tasked with some hard things. And so that's why I try to train the trainees. If there's a concerned and loving family member who stops the oncologist before going into the room of a newly diagnosed stage 4 colorectal cancer patient, and if the loved one says, before you go into the room, doctor, please don't tell them that they have cancer, or don't tell them that their prognosis, that can be hard for clinicians, especially clinicians in training who don't have as many years under their belts to know how to navigate. So I train them and I say, you need to know where this is coming from, and you need to work with this family. And the first place to know where it's coming from is not, this is my adversary, which we don't have adversaries as patients and families. But sometimes when people are pressured and they're pressed for time, they might feel annoyed that someone is telling them that they shouldn't say something which they think usually is the right thing to talk about. So I say, remember, this is probably a concerned family member. And so you should empathize with that. And just like the acknowledge, normalize, and partner framework, I teach the nurse mnemonic, and I teach it to all the trainees. And I say, you should recognize the love and concern of that family member. And you should say, I can see how much you care about them. But you should also inquire. You should use that Tyson curiosity, which is the E in nurse, which is explore. And you should say this: help me to understand your concern about them knowing what you're asking me not to tell them. And then they'll probably say, because I'm concerned it will devastate them, or because in my culture, we don't talk about those things, or in our culture, we have the information about serious illness and death go to a family member. And then you should say, thank you for telling me that. I am obligated to follow what the patient wants to know or not know. Let's go into the room together and let's talk about it. And you can see that I'm going to do this and respect their autonomy, as well as their autonomy to not hear information. And so I bring the family member in, and then I say to the patient, it's nice to meet you. Some people want to know all details. Some people want to know no details. I can speak to their family, and then there's people in the middle who want to know the high points of a certain medical illness. What about you? And a lot of those patients where you're stopped before going in the room, a lot of those patients say, talk to my loved one. I'm fine with you talking to my loved one, and that's okay. So that's a specific situation about the family member not wanting some information. And then to go back to, I think, what you were asking about, if the patient doesn't want the information, that information is garnered in the same way I just told you. This is why I open up the encounter with every single new patient I meet. No matter what I say, some patients want everything, some patients want nothing, some patients want the high points. What about you? Everything, nothing, or some. Usually they say all, but sometimes they say nothing. And sometimes they say, listen, I know I have stage 4 cancer, or I know I have cancer. I want to know generally where things are, but I don't want you to go into specifics about prognosis because that might scare me. And I say, I respect that. Now, oftentimes they don't say why they don't want it. It really is the obligation of the clinician to say, I respect that. Can you please help me to understand why you don't want that information? That's the curiosity that Tyson talks about. Because if we don't say it, then we don't know why, and we don't know if that person is misinformed or if they are informed and they're just concerned. Like you said, a lot of patients might assume that they have one day to live if they have metastatic colorectal cancer, even though, as we know, some metastatic colorectal cancer is curable. And even when it's not, people can usually live for years. So if the patient says, because I assume I'm going to die tomorrow, you can say, actually, that's not going to happen. Do you still not want to hear? And they might say, well, actually, good. I'm not going to die tomorrow. Okay, you can tell me a little bit more. So there's many ways to do it, but you really have to use those skill sets. And I could speak on and on for this, but that's the high points.
Okay, thank you very much. That was a great answer. So we'll go through some of the questions and then I'll get back to what other questions I have.
Sure.
So Julie asks, there is a gap in data regarding patient QOL on treatments. Since reported are event-centric toxicities for most treatments and limited published PROs. Does Dr. Epstein have suggestions regarding how to fill this gap when assessing patient options versus patient QOL goals?
Ask. just like Gawande said, people have priorities that they have besides simply living longer. The best way to find out about them is to ask them. So if the hospital system doesn't have a PRO system, then, or even if they do, okay, I see on your 10-point PROs, you have nausea, diarrhea, worry about the future, constipation, and tiredness. This is on the current chemotherapy. How is this going for you? Is this a constellation of symptoms that you are okay with living with if it means the cancer treatment's working? Or do you feel as if maybe we should lower the treatment doses a little bit in order to try to decrease these quality of life burdens, which probably won't have have a decrement on the effectiveness of the treatment, which is often the patient concern, and have a conversation with a patient about those things. There are some people for whom 3 days of nausea is not okay, and there's some people who would be okay with living through all of those constellations of symptoms that I mentioned. So you really have to ask about them. It's true that there is a dearth of quality of life evidence. Our data focuses too much on important things, but still too much on overall survival and disease-free survival and tumor regression, et cetera, et cetera, et cetera. These are all very important things, but we need more things on the quality of life indices. I think we've done a much better job in the last decades of getting more information. And, we do know, for instance, with, metastatic pancreas cancer, that the FOLFIRINOX regimen not only helps patients live longer, but it actually helps them feel better. We do have those data. And yet I think that we do have a dearth of quality of life data. I think that the EGFR inhibitors for colorectal cancer can often be with serious, if not unacceptable, quality of life detriment through the dermatologic manifestations of the disease. And I think that we don't have data saying that the EGFR inhibitors up front are better than using them later. So don't get me started. I agree that there's a dearth of quality of life of data, and we need to generate more of it. And before we generate the data, we need to ask patients.
Okay. Julie, if you want to add more, that's okay. I was kind of wondering if she was talking about like general quality of life related, most of when they collect these data as part of trials, it's mostly about the particular treatment that's being tested. Is that what you were?
Yes. Yeah. I was talking about kind of you're deciding between two treatments you haven't started yet. And, you're trying to decide which one's better for you. And all you can see is 30% of people had diarrhea, but you have no idea what that means in terms of like, does it mean you're not able to function for 3 days? Because that's important to me, so I love understanding kind of what's important to the patient, but then trying to figure out how to dimensionalize the treatments. I think that's a challenge for patients and also most oncologists, right? Because they don't have that data. So any thoughts on how to best bring that to life for people?
Sure. Do you mean they don't have that data of what if that patient's going to fall in the 30% who have diarrhea or the 70 who don't?
Or what that means. So for instance, I was on a trial and I had 2 acute events, grade 3 events that lasted 2 days each. They were treated, no big deal, right? But then I had 5 grade 1 and 2 that were prolonged, that together were a horrible experience. But in that trial data, right, nobody knows that those reported were by one patient and kind of how it played out in their daily lives. So
Yep.
trying to understand how to bridge that, because, we do that in Colontown with people describing their experiences so other people can kind of dimensionalize, but it's all anecdotal. So, it's hard.
Well, I think that you raised a critical point about how one day of a grade 3, let's say it was asymptomatic amyloid lipase elevation. I'm exaggerating, but that's, I just had to hold treatment for a patient of mine because I said, how do you feel? He said, I feel fine. I said, well, your amylase and lipase is really elevated. He said, so what? And I said, well, we have to hold it. And that was nothing to him. And yet there are some people, like in your experience, or as other people mentioned, you could have smoldering grade 1 or grade 2 nausea for 5-6 days. And that is really, really significant. And a detriment to people's quality of life. And that, I think, is true which is one of the limitations on our reporting mechanisms. It doesn't tell the whole story. I agree completely. And this just gets back to a well-informed patient by the clinicians. You might have what we deem to be mild, but a symptom that goes on for several days. And then the oncologists need to say, in my experience, it usually doesn't happen, or it does, or, so again, the EGFR inhibitors, you might have pimples on your face that we deem to be grade 1, meaning quote unquote mild. But we know human beings, not everyone, but a lot of people are sensitive about their social and their outward appearance. And they might say that 6 red dots on their face, which is technically, grade 1 or grade 2, is unacceptable, because that's not they're not going to want to live their life like that. And so these have to be discussions with patients and families by the clinicians, and there has to be a decision made thereafter. Sometimes, I think this was part of your question, there are treatments, there's a treatment choice, and treatments might entail something and another treatment might not. And I mean, I do this all the time with esophagus cancer. If we're talking about, taxanes versus irinotecan as the next treatment, we talk about sometimes there may be more diarrhea with irinotecan, but there's a more chance of hair loss with the taxanes. Or with colorectal cancer, when there's progressive colorectal cancer, and some agents such as regorafenib or TAS-102 often have side effects that should be discussed with the patient. These things need to be discussed, and they should have an option to not take those if they don't want those side effects, even if it might mean they're sacrificing a small amount of overall survival benefit with those agents.
Thank you.
So in relation to her question, what can be done to capture the dimensionality that she was talking about in terms of, grade 3 for 1 day versus grade 1 for a week or 2 weeks? I mean, what could be done to get that information in, say, clinical trials? Because, for patients, it's one thing being able to talk to your doctor, because then they would get more granular information. But when people are looking at published data and deciding if a trial is good for them, then seeing just the table of 30% grade 3 or 70% grade 1, it's hard to decide, what do you do?
Yeah.
Right?
Yeah, so I think that at least indirectly, a lot of that information is going to come out in the more global quality of life scores, which are increasingly used. So the fact there's a cadre of quality of life scales, both general as well as colon or cancer specific or social specific, called FACT, the FACT scores, functional assessment of cancer therapies or something like that. And I think a lot of these things will come out in that. So even if you have someone who's got 10 different side effects, but they're all grade 1, well, that could still really show itself up in the quality of life scales. So I think that that it'll come out somewhere else. Will there ever be a perfect system? No. And this is where I think it's really upon the clinicians to be honest with ourselves about, what is a grand slam success like an NTRK inhibitor, and what is, to continue with the baseball analogy, maybe a bunt single, and not very, very extremely helpful and with some hardship involved in the land of colorectal cancer or other. And they have to communicate that. The easiest thing an oncologist can do is say, well, technically the next treatment is X, so this is kind of what happens. You want to think about it, and we could do that. Let me know. That's the easiest thing for someone to say, and it's the quickest thing. Less easy would be, there technically is this option. I have concerns about it because of the relatively large number of side effects that are associated with it and the relatively small gain in overall survival. I find that only a small subset of my patients find this to be valuable for them. This is what it entails. These are the detriments. What type of person are you and what's important to you at this time? That conversation takes longer. And yet that's what a clinician is, I believe, mandated to do and must do. Otherwise, we're just giving drugs, and it's not as helpful or targeted or precise for each patient.
Okay, thank you very much. So we'll look at the next question because we don't have too much time. Jamie asks, how does a doctor set aside their biases or leave their experience to the side when decisions need to be made about care? How do you handle a doctor that might let their biases influence how they present things?
I smile because that's what so much of this talk is about, and that's what's so important, which is that we're all human and we all have biases, and there's no answer to that question. There's no quick answer to that question. It is based out of our humanness. It is based out of the time pressures that we all have, and the fact that it's easier for me to do something that is towards my bias, or just easier. In fact, I will be biased to do something that is quicker and easier for me, when in fact the right answer is doing the opposite. And so awareness, having clinicians be self-aware. How do you make a clinician be self-aware? Well, that's hard also, especially in increasingly topsy-turvy worlds, including an increasingly pressurized medical environment as well. So it's a societal question. It's a upbringing question. It's a parenting question. It is myriad things, and it's extremely important.
I will go back to what Julie asked. So what I was wondering was that, like, in addition to the drug-specific quality of life endpoints, maybe if there was a way to include the fact type of questionnaires, then do you think that we would be able to get a more balanced view of the drug-specific quality of life things, and also what is generally affecting the patient's lives? Is that something that could be done?
I think it could be done. I think that it's probably being worked on. It's not my area of specialty expertise or research, looking at quality of life as it relates to specific pharmacologic compounds themselves, and yet I know that it is increasingly part of what's deemed important by funding bodies like NIH and the PCORI, which is the Patient-Centered Outcome Research Institute. And so I have faith that this is being looked at. I am concerned that we might not be able to do it as quickly as might be helpful for patients because of the factors that drive drug development. And then it goes back to having a team, including an oncologist, who can be asked questions about what is most likely and what is the most likely thing to happen or to be best for a patient, given the patient's priorities, which the patient really needs to speak up about if not asked.
Okay. Thank you very much. The one other question that I have is, like, for example, with colorectal cancer, this is how I feel. Like, we have very few lines of therapy, right? We have 2 good lines, and then we have maybe now this Lonsurf, Bev, and then maybe fruquintinib. We have very limited lines. But when a patient starts the treatments, many of them are not told, like, what's the landscape of the whole treatment scenario that's available, right? And like, I mean, maybe you don't have to go to the granular, like, yes, you'll get this much, this many months to this many months on first line and this many to this many in the second, not that much, but at least to be told that there is a limited set of things that can be done. Because what we find is that when we ask patients to think about clinical trials, they give us the answer that, oh, their care team said, you have plenty of options, so you don't need to think about it. And then they don't think about it. And by the time, they are told, okay, you have gone through all lines, now you have to look at clinical trials, and they are like, what we call the oh shit moment, where they've not prepared for it. So what can you advise patients how to have this conversation? They don't want to know that they will only live till 5 years upfront, right? But how to convey this information in a way that is more realistic, but without, like, scaring people.
So patients, if the oncologist is not giving this information and they want it, the patient should say to the oncologist, I'm not asking you to predict the future or to tell me how long I have to live. I am asking you if you could just spend 1 minute telling me generally what the landscape is in terms of the approximate number of treatment lines, approximately how long each line might work for on average, not holding you to anything. And they should say that if they want to know that. Because you're right, the rug is pulled out from under people, and they do have the oh shit moment, which is not fair to patients. It is not intentional by doctors, but it is part of that bias where, and I say it sometimes also, there are options. There's several options. What does several mean? Several can mean 2 and 3, like you said, or it can mean dozens. And as you say, we don't have dozens of viable treatment options in metastatic colorectal cancer. And so, oncologists should be saying, we hope for the best, that you have a relatively indolent disease biology, and that we will be able to use several and have benefits. And we prepare for the worst in case we're not even able to use them all. And we need to recognize that usually we just don't have as much time on each one, and that there aren't as many as we hoped. But we do hope that we will have a relative goodness for you. Help me to understand what relative goodness for you means, et cetera, et cetera. So I try to use the hope for the best and prepare no matter what statement, so that the preparing no matter what, or so-called preparing for the worst, is something that can plant a seed, for lack of a better term, in the mind of a patient and family members, not to scare them and not to be a Debbie Downer, but to let them know that unfortunately there's limitations with an incurable cancer, like many metastatic colorectal cancers, and we're going to support you and do the best we can, and hope that we have an atypically good outcome. And we're going to be a team no matter what, including if we don't get what we hope for. And so I plant that seed, and my patients do have the oh shit moment sometimes, but I can't quantify this, but it feels like not as often as, maybe when I did it less well in the past, or I don't know, I can't really compare myself to others, but I agree with you completely. There needs to be some discussion, if patients want it, of what generally happens and what the expectations for landscape treatment is.
Okay. Thank you so much. We have gone past the hour. Thank you so much. This was very informative, and so we'll have the video edited and then the transcripts, and it'll be posted on Colontown University. So thanks again for doing this with us.
Thank you for having me. Have a good day.
You too. Thank you. Thanks, everyone. Bye.